immunotherapy for the treatment of cancer. It's perhaps not as precise as femtosecond laser surgery, but perhaps more so than the blunt instruments we have today, like chemotherapy and radiation therapy for treatment of cancer. The work I'll be discussing involves targeting melanoma cells with the T cell. I'm standing in the right place here. And this is essentially what happens. The T cell recognizes and kills a tumor cell. I don't know how you guys did this. I'll stand right here. And what we'd like to see is senescence of these cells. Oh boy. You know what? Right. We'd like to see these cells senesce and these cells not senesce. Basically, that's the theme of my talk, and how to get these cells to persist. Will involve methods to augment the survival of these T cells as well as their function by manipulating them in vitro and in vivo. For a little bit of basic immunology here, as normal cells progress to tumor, they break normal tissue barriers and induce an immune response that results in the activation of the innate response effector cells, such as natural killer cells, complement some of the NKT cells. The tumor releases a little bit of protein, and this is picked up by the linchpin between adaptive and innate immunity. The dendritic cells, which then take these proteins back to draining lymph nodes. They're little helper CD4 and CD8 T cells. These are induced to expand in a specific manner through its T cell receptor. As these expand, they travel back to the tumor cell and hopefully eradicate the tumor. However, this is known as immune surveillance, and if this is what's occurring, then why do patients continue to develop cancer? And probably this is continuing. This is a continuous process, and in some cases these cells are dormant, and clearly that Bob Schreiber has already shown, for example, that interferon gamma and perforin, for example, are important in terms of suppressing the immune response. However, the possible reasons for failure of tumor immune surveillance is tumor has very clever ways of evading the immune system by suppressing antigen, by releasing factors that suppress the normal effector responses. And also it's a question of numbers, T cell frequency and the tumor burden, and we can address both of these by producing highly functional T cells and basically getting more of them. But really, the practical ways of doing this is by vaccine therapy. This sort of recapitulates what's been done in treating a virus and bacterial, or primarily virus-specific responses by taking immunogen and repeatedly immunizing patients to induce an endogenous immune response against the tumor. We've taken the approach of adoptive cellular therapy, where we've isolated these T cells ex vivo and expanded them to large numbers and then reinfused them back into the patient. So this is a much more rigorous and time-consuming process than vaccine therapy, which is potentially more universally applicable. However, this provides very rigorous control over the effector cell, the magnitude and the specificity. And it also removes any afferent components required. There's talk whether cancer suppresses patients, whether this occurs or not. The endogenous population of the antigen-specific T cells is very low in frequency, and inducing that response in vivo can be problematic. We sort of subvert that, circumvent that, those obstacles by infusing T cells and then concentrating on the afferent response. As I mentioned before, the advantages of using antigen-specific T cell clone provide very rigorous control of the specificity, phenotype, and magnitude of induced response, and I'll explain to you how we manipulate these factors in order to augment function and also anti-tumor efficacy. So the question is it sufficient just to transfer large numbers of T cells? And apparently not. Otherwise, we would have cured a lot of cancers by now that we can cure in mice. And this is studies dating way back about, actually I don't have the date here. Right? It's 20, 30 years. And in this mouse model, if you give the mice no therapy, they don't survive very long. They drop off right away within 2 to 3 weeks. If you just give them antigen-specific T cells, even large numbers, the mice also don't do quite so well either. If you give them high-dose Cytoxin, that type of chemotherapy, but also, as it turns out, a conditioning regimen for T cell therapy. But if you give Cytoxin alone, you see no significant response. And the combination of Cytoxin and antigen-specific T cells provides long-term survival for these mice. So the question clearly is that you need more just than giving T cells to these mice. You need to give perhaps a special type of T cell, or T cells in combination with other immunomodulators. And so the basic protocol which we published in a phase 1 clinical trial several years ago, involved isolating, expanding antigen-specific CD8 positive T cell clones and infusing that back into patients, either by selecting them, in this case with a clinical cell sorter, although we don't have such a machine in use at that time, we did brute force cloning, isolated those clones which were specific for a specific tumor antigen, in this case melanocyte-associated differentiation antigens found on melanoma cells and also known to induce an immune response. Those epitopes that are known to induce immune response were used to generate these T cell clones in vitro, expanded to several billion in number, up to 10 billion cells per meter squared, and then infused into the patient. And when we look at this initial protocol, you can arbitrarily divide this into intrinsic and extrinsic factors that can be used to manipulate and augment the response. And you can do this at several points in the cycle, either by modulating the T cells in vitro by selecting for CD8 T cell clones or CD4 T cell clones, perhaps selecting those with a high replicative potential, those with essential memory phenotype, for example, genetically modifying them to provide them with redirected specificity or enhanced function. And once you have this, there are various ways to expand these. Before giving them to the patient, however, you can condition them by lymphodepletion with chemotherapy or radiation or other more specific reagents, or post-infusion with various cytokine or immunomodulators. And I'll discuss a little more about this as we move on to the second trial. So I'm going to tell you two stories. One is using CD4 T cell clones. We've already discussed the use of CD8 T cell clones, and that was published several years ago, and it's shown that these T cells persist with limited durability in vivo because of the requirement for continuous growth factors. We gave them low-dose IL-2 that extended their survival to 2 or 3 weeks. However, we're looking for durations much longer than that in order to maintain tumor regression. And the other extrinsic factor to look at is lymphodepletion. So with CD4 T cell therapy, why choose CD4 T cells? CD8 T cells release perforin and lytic granules. They kill the tumor directly. CD4 cells can also kill tumor directly, indirectly, by recruiting other effector cells such as macrophages or eosinophils. They can also directly kill by contact through fast-pass ligand release of cytokines. However, they also provide helper functions in gyrus effector cells. They release growth factors like IL-2 or the gamma chain receptor cytokines that can induce and augment an endogenous immune response, as well as support those which are also transferred. They can also license APCs, that is the license to kill, I guess, is the acronym that they've been given, is that they activate dendritic cells so that they can also further augment an endogenous response against the tumor. And so CD4 T cells function both themselves as direct or indirect killers and also to support endogenous responses. And so to isolate these CD4 T cell clones, we collect the white blood cells from patients, stimulated them in vitro with autologous dendritic cells, and after iterative cycles of in vitro stimulation with low-dose gamma chain receptor cytokines, these cells were then enriched in the culture dish for targeting a melanocyte-associated antigen. In this case, it was tyrosinase or cancer testis antigen known as NY-ESO1. So these CD4 T cells, through direct interaction with T cell receptor for its epitope peptide C complex, can kill tumor directly, be activated, release cytokines, and support adoptive therapy and endogenous responses as well. These are then infused into the patient. This was a phase 1 study, a dose escalation study, because nobody had given any specific CD4 T cell clones before to patients. People have given a mix of cells without knowing what their specificity was, but this was a uniform population of CD4 T cell clones that targeted either tyrosinase or the NY-ESO antigen. We treated patients who had progressive metastatic disease, for which there's very little options available, really only 2 types of therapy, high-dose IL-2 or low-dose chemotherapy. And in these patients, they uniformly were progressing at the time they received therapy. They had expected survival of less than 1 year, and patients had progressive metastatic disease and were given a single dose, initially at 1 billion cells per meter squared, and in the half-log increments, an assignment 2-step trial design, up to 10 billion cells per meter squared. This was published recently in the New England Journal of Medicine for the 1 patient, but I'll report all the results of the 9 patients shown here. The first 3 patients given at the lowest dose level here of 1 billion cells per meter squared have been heavily pretreated. We targeted either NY-ESO1 or tyrosinase. They had significant measurable disease, and unfortunately all these patients progressed even after therapy. The next 3 patients, again, similar pretreatment profile, significant visceral and subcutaneous disease were treated with CD4 T cells targeting NY-ESTER1. There was a complete response, I'll tell you more about that in a minute, and a patient whose disease stabilized for at least 4 months before progressing again. And then finally, at the highest dose level, we saw patients again with heavily pretreated histories and significant tumor burden, seeing a partial response in one patient and stabilization of disease. We went back and treated some of these other patients at the higher dose level, and you can see that there might be a dose-response effect in this patient. Patient had progressive disease and now stabilized for at least 9 months, and it's a continuous